But there was also another study that was presented as part of the orals. Dr. Sabi George presented the 69 study that was looking at a different formulation of nivolumab, looking at subcutaneous nivolumab instead of IV nivolumab. And it was given on a 4-week schedule compared to IV Nivo given Q2 weeks, largely done outside of the US in the refractory setting. What are your thoughts about subcutaneous nivolumab? How do you think this is going to pan out?
Well, I think, there is pressure. Unfortunately, we are facing, the healthcare system in the US and Europe is facing shortage of nurses. And there is also constraints on space. So if we have any therapy that we can give subcutaneously instead of intravenously and, holding a chair for an hour or longer, to give an IV nivolumab, for example, I think that will be welcome. We had a discussion with our European colleagues last night, and they expressed the same thought, that in Europe, they have problems with space and nursing shortage. And so they really embraced and were very excited that there is potential to give nivolumab subcutaneously. I think, 70% of patients with cancer are treated in the community, as we all know. So how do our community oncologists receive this news, and how would that, change their practice? Would they embrace it and give it to their patients subcutaneously instead of... Now, obviously, if we are talking about giving Nivo-IPI, then they're going to have to sit in the chair to get the IPI. So probably just get the nivolumab half an hour and they'll get that. But if they are getting an IO and a TKI, then I think, they can get that injection and then walk out within 5 minutes from the clinic. But to really know how this is going to change the practice of what we do at academic centers and in the community, we really need to see the cost of this.
Yeah.
If this 1,200 milligram nivolumab given sub-Q is going to be by far more expensive than nivolumab intravenously, is this good for our healthcare systems? Yeah. And patients may not, they like the idea of convenience of a sub-Q injection, but if this is going to add to their cost, this is going to be a problem.
Yeah, I 100% agree with you. I think the bigger picture is, right, patents are running out, right? And yes, it appears altruistic to now go to sub-Q, but there's also financial interest, right, in having now a different modality, how to give the drug. It will extend the patent life and the revenue and all these things. So that's one of the drivers. And I would say, why giving sub-Q, for example, in a treatment center when we're giving so many antibodies, now virtually any therapeutic antibody, these patients are taking it at home, right, at their leisure, right? So, but you're absolutely correct. All of a sudden, it's not an infusion anymore. Co-payment issues, all kinds of things, right? Financial toxicity to the patient, loss of revenue in private practice if they don't do the infusions anymore, private revenue loss for cancer centers, et cetera. So I think it's actually a complicated topic, but I agree with you. I love innovations like that. I think it's a great idea from a convenience perspective, from a time-saving perspective. I don't want to drive to some distant center if I live in rural areas, 2 hours just to get the infusion. If they can ship the drug to me and I can inject it myself, right? Go directly to the patient, but then after the doctor signs off, right? But then again, make it in a way that it doesn't worsen the cost already on a strained healthcare system.
Yeah, I think a little bit about that too is, I worry about the monitoring. Right now there's very strict criteria. You have a treatment plan in place. There's, blood parameters, liver parameters. This isn't just like, an LHRH analog in the clinic that you just get it and go, and you don't need to check any labs beforehand. So I think, we need to continue to maintain the rigor of the monitoring of labs. And, as I understand it, it's, this is not a injection that patients can actually self-administer. It's a viscous solution, or somewhat viscous, that actually needs to be slowly injected over a 5-minute period, probably by a healthcare professional. So, but I do think it's, it's always good to have options and always good to have access, but I think doing a cost analysis is going to be critically important, and doing an analysis of actually what is the time gained, like from the moment that the patient steps into the center, because they have to get their labs, the labs have to result, they need to wait for the labs, they have to see the doctor. So, how much do you actually save is going to be important.